want to begin with a case that has nothing to do with BID. An unconscious patient is rushed into intensive care bleeding heavily. The medical team finds the source of the bleeding, prepares a transfusion, and works to stabilize them. Under ordinary circumstances, this is medicine doing exactly what we expect it to do, preserving life. Now, change one detail. The patient is a Jehovah's Witness, a member of a Christian denomination whose followers commonly refuse blood transfusions on religious grounds. The medical team knows that this patient made a clear and valid refusal while they were conscious and capable. No effective blood substitute is available. A transfusion would probably save the patient's life. It would also violate a decision they had explicitly made about their own body. The doctor now faces two forms of harm: transfuse the blood and override the patient's values, or respect the refusal and accept that the patient may die. So, what does the doctor do? Save the patient's life by overriding the values through which that person understands dignity, faith, and bodily integrity. Or honor the refusal, knowing that the patient may die. Where a valid advance refusal exists, the doctor must respect it. The ethical tension remains. A transfusion preserves biological life while violating an autonomous decision. Refusal protects autonomy while allowing preventable death. Both paths contain harm. There is no neutral outcome. That is the problem we will examine today. With body integrity dysphoria, medicine faces a comparable conflict. Amputation removes a healthy limb and permanently reduces physical function. Refusal may prolong severe dysphoria and, in some cases, drive the person towards dangerous self-injury. Each response protects something. Each response sacrifices something. This is Contested Bodies. I'm Leandro Loriga. Welcome to episode 5, Cutting and Consenting. Today, we examine the ethical principles medicine uses to navigate these conflicts, and how far those principles actually take us. Welcome back. A quick orientation. In episode 4, we compared BID with gender dysphoria through the principle of justice. Similar cases should receive similar treatment unless an ethically relevant difference justifies the distinction. Today, we widen the frame. When someone asks for an irreversible operation on a healthy body, which ethical principles should guide the doctor? And what happens when those principles point in different directions? We will examine 4 ideas that dominate modern medical ethics. Autonomy, the patient's right to make decisions about their own body. Beneficence, the duty to promote the patient's well-being. Nonmaleficence, the duty to avoid harm. And justice, the demand for fair and consistent treatment. We will also turn to Harry Frankfurt, an American philosopher known for his work on freedom, responsibility, and the structure of human desire. His account helps us move beyond the question:
does the patient want this?
It allows us to ask more demanding questions.
Does the person identify with the desire? Do they endorse it? Do they want it to guide their actions?
When I began examining BID, I expected harm to be the most difficult part of the argument. Removing a healthy limb appears at first sight to give us an obvious answer. Autonomy proved far more complicated. A patient may understand the procedure, accept its consequences, and express the same desire consistently for decades. Medicine must still decide whether the choice should count as autonomous. That is where most of today's episode will take us. We begin with the 4 principles. Tom Beauchamp and James Childress are American bioethicists whose work helped shape modern medical ethics. Their best-known framework is built around 4 principles. Autonomy. Respect the patient's ability to make decisions about their own life and body. Beneficence. Act for the patient's well-being. Non-maleficence. Avoid causing harm. Justice. Treat people fairly and apply similar standards to similar cases. Together, these principles are often called principlism. They provide medicine with a common language for discussing difficult decisions. The framework has critics and it cannot produce an answer automatically. There is no ethical calculator where we enter the facts and receive the correct decision. Its value lies elsewhere. It forces us to identify what is at stake. With BD, all four principles become active at once. Autonomy asks whether the patient's informed and stable choice should be respected. Beneficence asks which response is most likely to relieve suffering. Nonmaleficence asks which harms follow from surgery and which follow from refusal. Justice asks whether BID is being treated consistently with comparable medical conditions. The principles have no fixed ranking. Autonomy does not automatically defeat beneficence. Non-maleficence does not automatically settle every case because an intervention alters healthy tissue. Beauchamp and Childress instead ask us to examine the particular situation, clarify what each principle requires, and balance competing obligations. The framework reveals the conflict. Judgment still has to resolve it. There has also been a major historical shift in medical ethics. Traditional medicine gave greater weight to beneficence and non-maleficence. The doctor was expected to judge what would help the patient and protect them from harm. This often produced paternalism, the belief that medical professionals could override a patient's wishes because they knew what was best. Over recent decades, autonomy has moved closer to the center of clinical practice. Patients are now expected to participate in decisions, receive information, and make choices according to their own values. Autonomy is sometimes described as first among equals. It still does not automatically defeat the other principles, but medicine can no longer dismiss a competent patient's request because the doctor finds it disturbing or unwise. That shift places pressure on the response to BID. A paternal approach can say removing a healthy limb is harmful, therefore the request ends here. An autonomy-centered approach must go further. It must examine whether the patient understands the consequences, whether the choice is stable, and whether refusal creates harms of its own. We can now apply the four principles directly to BID. I will begin with beneficence, the duty to promote the patient's well-being. Beneficence is the doctor's duty to promote the patient's well-being and relieve suffering. Apply that principle to BD. The patient may have lived for years, sometimes decades, with persistent distress about their body. Studies and first-person reports suggest that psychotherapy and psychiatric medication often fail to remove the central desire, although they may help with anxiety, depression, or the distress surrounding it. The evidence on amputation is limited. We have small studies, individual cases, and self-reported outcomes rather than large clinical trials. Still, the reports we do have are difficult to ignore. Patients who obtained amputation, including those treated in Falkirk, often described substantial relief. Some said they finally felt complete or able to live normally in their bodies. From the perspective of beneficence, that creates a serious argument. There is a patient experiencing severe and persistent suffering. Conventional treatment has often failed to resolve the central problem, and an irreversible intervention, although drastic, has brought relief in some reported cases. Beneficence, therefore, gives the doctor a reason to consider amputation as a possible treatment. It does not create an automatic duty to operate. The evidence remains small, the surgery carries permanent consequences, and the long-term risks require careful assessment. But the principle cannot be used only to defend refusal. If amputation may relieve suffering where other approaches have failed, beneficence places the possibility of surgery inside the ethical discussion. Beneficence is what Beauchamp and Childress call a prima facie obligation. Prima facie is Latin for at first sight or on the face of it. In practical terms, it means that the duty normally applies, unless another ethical duty carries greater weight in the particular case. A doctor should promote the patient's well-being. That obligation may still be overridden if the proposed action would cause greater harm, violate the patient's autonomy, or create a serious injustice. Two objections are commonly raised against the beneficence argument for BID. The first is the slippery slope. If medicine accepts amputation as treatment for one condition involving a psychologically driven desire, where does the precedent end? Crude slippery slope arguments are weak. Permitting one carefully assessed intervention does not automatically commit medicine to accepting every future request for bodily alteration. There is, however, a more serious version of the concern. Ian Hacking was a Canadian philosopher of science known for studying how medical and psychiatric classification affect the people placed within them. He called this the looping effect. The basic idea is that a diagnosis can change the experience it was created to describe. Once a condition receives a name, people can recognize themselves in it. They gain a vocabulary, encounter others with similar experiences, join communities, and learn what symptoms or life stories are associated with the category. The classification then begins to influence the people classified under it. Imagine someone who has felt uncomfortable with a limb for years but has never understood why. They encounter BID online, read detailed accounts, and begin to interpret their own experience through the diagnosis. The category has not created the discomfort from nothing, but it may give the discomfort a clearer shape, narrative, and possible destination. An established pathway from BID diagnosis to amputation could therefore influence who identifies with the condition and how the desire is expressed. This does not mean that recognition would cause large numbers of people to seek amputations. It means that medical categories can alter the population they describe. I do not know how much weight this concern should carry in BID. It deserves consideration rather than dismissal. The second objection is more immediate: legal and professional exposure. Amputation for BID is not an established standard treatment. A surgeon who performs it may face disciplinary proceedings, civil claims, loss of professional protection, or, depending on the jurisdiction and circumstances, possible criminal investigation. A doctor may therefore believe that surgery could relieve a particular patient's suffering and still refuse because the institutional and legal risks are too great. That distinction is important. The refusal may arise from the absence of recognized standards, regulatory protection, and professional guidance, rather than from a clear conclusion that surgery violates beneficence. The ethical case and the institutional permission are not the same thing. Beneficence may give the doctor a reason to consider surgery. The surrounding system may make acting on that reason professionally impossible. This brings us to nonmaleficence, where the objection appears most direct: the duty to avoid harm. Nonmaleficence is the duty to avoid causing harm. It is often summarized by the Latin phrase primum non nocere. First, do no harm. That sounds clear until every available option carries harm. The Jehovah's Witness case from the opening shows the difficulty. A transfusion may preserve life while violating a decision grounded in faith, dignity, and bodily integrity. Respecting the refusal protects autonomy while allowing the patient to die from a treatable condition. The principle identifies the harms. It cannot decide which harm should carry greater weight. BID creates a comparable conflict. The first option is amputation. The surgeon removes a healthy limb. Physical function is reduced. The change is permanent. Surgery carries the usual risks of bleeding, infection, complications from anesthesia, rehabilitation, and long-term dependence on prosthetic or assistive support. Phantom limb sensations are also common after amputation. Some people experience phantom pain, which can be severe and persistent, although the outcome varies considerably between patients. The second option is refusal. The patient continues to live with dysphoria that may already have lasted for years or decades. Some attempt to destroy the unwanted limb themselves through freezing, crushing, deliberate injury, or other dangerous methods intended to force an emergency amputation. Others continue living with the psychological burden of being told that the bodily state they experience as necessary will never be considered. The harms are different. Surgery creates visible and irreversible physical loss. Refusal may preserve physical function while prolonging psychological suffering and leaving the risk of self-injury unresolved. Non-maleficence therefore gives medicine no easy escape. The ethical task is to decide which harm carries greater weight for this patient in these circumstances. Non-maleficence cannot answer that question by itself. The principle tells the doctor to avoid harm. Once every available option carries harm, another kind of judgment enters. What counts as harm? How should physical loss be weighed against psychological suffering? How much weight should be given to permanence, function, pain, identity, and the risk of self-injury? And whose understanding of harm should guide the decision? When someone says the doctor would be harming the patient by amputating, they are identifying one genuine harm, the deliberate removal of a healthy limb. They have not yet completed the ethical argument. Refusal may also harm the patient by prolonging severe dysphoria or leaving them exposed to dangerous attempts at self-amputation. The disagreement therefore concerns how different harms should be valued and compared. Physical harm is visible, measurable, and familiar to medicine. Psychological suffering is harder to see and easier to discount. Giving priority to one over the other may be defensible, but it remains a judgment rather than a conclusion supplied automatically by the principle. The doctor and patient may also understand harm differently. The doctor may see the loss of the limb as the central injury. The patient may see continued possession of the limb as the injury and amputation as relief. When those views diverge, medical authority and patient autonomy come into direct conflict. That brings us to autonomy. Autonomy is the patient's capacity to direct their own life and make decisions about their body. In medicine, it includes freedom from coercion. A competent adult cannot ordinarily be forced to accept treatment. It also requires informed consent. The patient must receive enough information about the procedure, its risks, its likely benefits, the available alternatives, and the consequences of refusing it. There is an important limit. Autonomy gives patients a strong right to refuse treatment. It does not automatically give them the right to demand any intervention they choose. A doctor still has professional duties and may refuse a procedure they consider harmful, ineffective, or outside acceptable practice. Applied to BID, autonomy therefore creates a serious claim rather than an automatic conclusion. Suppose a competent adult understands what amputation involves. They understand that the limb is healthy, that the operation is irreversible, that function will be lost, and that rehabilitation, phantom sensations, pain, and social consequences may follow. They still request the operation. The next question is whether the desire itself undermines their ability to choose. Perhaps the request arises from delusion or some other disturbance of judgment. If so, the person may be unable to understand the decision in the way valid consent requires. That objection deserves careful examination. An unusual decision is not evidence of incapacity by itself. Capacity is assessed in relation to the particular choice. Can the person understand the information, appreciate how it applies to them, compare the option, and communicate a stable decision? The fact that most people find the request irrational cannot settle that assessment. So, we need to ask whether BID is actually delusional and whether the person's reasoning about amputation remains intact. The DSM describes a delusion as a fixed false belief that remains resistant to clear evidence. There is also a concept used in philosophy and cognitive psychiatry called a monothematic delusion. This refers to one highly specific false belief appearing within an otherwise fairly ordinary mental life. Capgras syndrome is the classic example. A person recognizes the face of a partner or family member, yet becomes convinced that the person has been replaced by an identical imposter. Someone might try to interpret BID in the same way. The argument would be that
"This leg is not mine"
is one isolated false belief held by a person who otherwise understands reality perfectly well. If that were true, the request for amputation might be based on delusion, and the patient's decision-making capacity would require closer examination. The evidence does not support that as the general explanation for BID. There is a second issue. Even when a desire has irrational, obscure, or emotionally driven origins, the person may still reason coherently about what to do with it. They may understand the available options, compare the risks, anticipate the consequences, and explain why one course of action appears preferable. I have argued elsewhere that demanding perfectly rational origins for every desire would set an impossible standard for autonomy. Human desires emerge from childhood, temperament, attraction, fear, habit, memory, and experiences we may never fully understand. Very few of us could give a completely rational account of why we want the lives, relationships, careers, or bodies that we want. Decision-making capacity, therefore, concerns how a person reasons about a choice, rather than whether every desire behind it arose through pure reason. The delusion objection does not dispose of the BD patient's claim to autonomy. The request remains unusual and medically controversial. It may still require prolonged assessment. Yet, unusual content alone does not make a decision delusional or incapable. We now need a more precise way to examine desire itself. Does the person experience the desire as an alien impulse they wish to resist, or do they reflect upon it, identify with it, and want it to guide their actions? Harry Frankfurt, an American philosopher known for his work on freedom, responsibility, and the structure of desire, offers a useful framework for answering that question. Harry Frankfurt was an American philosopher whose work focused on freedom, moral responsibility, and the structure of human desire. In 1971, he published an influential paper titled Freedom of the Will and the Concept of a Person. When we say that someone freely chose an action, what do we actually mean? Wanting something is rarely as straightforward as it sounds. We can want an action. We can also approve or disapprove of that desire. And we can decide which of our competing desires we want to guide what we do. Frankfurt separated these layers into first-order desires, second-order desires, and second-order volitions. Let us take them one at a time. The first layer is what Frankfurt calls a first-order desire. This is an ordinary desire directed towards an action or object. You are thirsty, so you want water. You are hungry, so you want food. You want to call someone, leave a room, take a drug, or avoid an unpleasant task. The structure is straightforward. I want X. The second layer is a second-order desire. This is a desire about one of your own desires. You may want to want something. You may also wish that you did not want it. Frankfurt uses the example of an unwilling addict. The addict has a powerful first-order desire to take the drug. At the same time, they wish they did not have that desire. They may want to desire sobriety instead. This shows that a person can experience a desire while also taking a position towards it. We do not only want things, we also approve of some desires, resist others, feel ashamed of them, or wish that our motivations were different. The third layer is the second-order volition. A second-order volition is a desire about which first-order desire should become effective, which desire should actually move the person to act. Imagine that the addict feels two competing desires. One desire says, take the drug. Another says, walk away. The addict may want the desire to walk away to guide their behavior. They identify with the desire and want it to become their will. For Frankfurt, the will is the desire that actually moves a person into action. Freedom, therefore, depends on alignment. A person acts freely, in Frankfurt's sense, when the desire that moves them is also the desire they want to move them. They want X. They endorse wanting X. And they want that desire to guide what they do. The unwilling addict experiences the opposite. The desire to take the drug becomes effective, while the person wishes that another desire were in control. No one may be physically forcing them, yet their action is being driven by a desire they reject. Frankfurt's framework therefore asks a more demanding question than, did this person do what they wanted? It asks, did they act from the desire they wanted to govern their actions? Now, apply Frankfurt's framework to BID. Does the person want the amputation? By their own account, yes, the desire is often stable and may persist for decades. Does the person endorse that desire? Do they want it to guide their actions? Or do they experience it as an alien impulse, something imposed upon them and resisted by the self they identify with? Does the patient experience this desire as their own? Accounts from people with BID often suggest that the desire itself is not experienced as the foreign object. The desire for bodily change may be woven into the person's identity, repeatedly considered, and endorsed over many years. Some may wish they had never developed BID. They may wish they could feel at peace with their existing body and avoid surgery altogether. That does not necessarily mean they reject the desire for bodily congruence. They may regret the situation while still endorsing the conclusion that amputation would bring the body into alignment with themselves. Such a desire may count as one the person identifies with and wants to govern their actions. This is an interpretation, not proof that every person with BID chooses freely. Some people may feel divided. Their desire may shift, conflict with other commitments, or be experienced as intrusive and unwanted. A careful assessment would need to examine the difference. Frankfurt's framework therefore resists the blanket claim that the amputation request is only a symptom and cannot express autonomous choice. For at least some people with BID, the reported desire appears stable, reflective, and integrated into their sense of self. That gives medicine a reason to examine the request as a potentially autonomous choice rather than dismiss it in advance. There is one more objection often raised against BD consent. How can someone truly consent to amputation when they have never lived as an amputee? They may understand the operation in theory. They have never experienced the loss of function, rehabilitation, phantom sensations, dependence on assistive devices, or the social reality that may follow. According to this objection, the consent cannot be fully informed because the future state remains unknown. The concern sounds reasonable. Applied consistently, however, it creates an impossible standard. A living kidney donor cannot experience life with one kidney before making the decision. Every irreversible choice contains uncertainty. Valid consent, therefore, does not require prior experience of the outcome. It requires an adequate understanding of the procedure, its likely consequences, its risks, its possible benefits, the alternatives, and the uncertainty that remains. The patient does not need certainty. They need enough information to make a reasoned decision. For BID, this would require a serious assessment. Does the person understand the permanent loss of function? Do they understand surgical complications, rehabilitation, phantom pain, prosthetic use, and the practical consequences of disability? Have they considered alternatives? Can they explain why they continue to prefer amputation after confronting those consequences? Those are legitimate questions. Demanding that the patient already know what life as an amputee feels like goes further. By that standard, almost no one could consent to an irreversible operation or life-changing medical treatment. With BID, uncertainty can suddenly become evidence that valid consent is impossible. The standard begins to move according to how acceptable the request already appears. Justice asks whether medicine applies comparable standards to comparable cases. We examined this fully in episode 4. Here, one point is enough. BD is recognized as a medical condition, yet requested amputation remains almost universally excluded from clinical practice. Similar levels of scrutiny are not always applied to other procedures that alter healthy bodies to relieve suffering or improve well-being. Calling BID amputation cosmetic does not settle the issue. Cosmetic and reconstructive procedures are sometimes offered when bodily appearance or configuration causes serious psychological distress. Resource limits also require consistency. Every health system decides which treatments deserve funding, but BD cannot be excluded through a cost argument that is not applied equally to comparable interventions. Private access creates another problem. Restricting a possible treatment to those who can pay would make wealth, rather than clinical need, the deciding factor. None of this proves that amputation should be funded or routinely offered. It shows that refusal still requires a principal explanation. Justice, therefore, returns us to the same question. Which ethically relevant difference justifies treating BID unlike other conditions in which bodily modification is considered a legitimate response to persistent suffering? With that question still open, we can ask what the 4 principles framework has actually given us. The 4 principles do not deliver a final verdict on amputation for BD. They make the disagreement clearer. Beneficence gives medicine a reason to consider surgery. The patient is suffering, conventional treatments have often failed to resolve the desire, and the limited reports available describe substantial relief after amputation. Nonmaleficence reveals 2 different harms. Surgery removes a healthy limb and permanently reduces function. Refusal may prolong severe dysphoria and leave the risk of dangerous self-injury unresolved. The principle identifies both harms without deciding how they should be weighed. Autonomy requires medicine to take the request seriously. Many patients appear to understand the consequences and express a stable choice. Frankfurt's framework adds another question: whether the person identifies with the desire and wants it to guide their actions. For some people with BID, the available accounts suggest that they do. Justice asks why bodily modification is accepted in some cases of persistent suffering and excluded almost entirely in BID. Taken together, the principles do not prove that amputation should be offered. They also fail to support an automatic refusal. What emerges is a serious and unresolved ethical case. Medicine still owes the BID patient a reasoned response rather than a reaction based on shock or intuition. The patient may satisfy the ordinary requirements of decision-making capacity. They understand the operation, appreciate its consequences, compare the alternatives, and communicate a stable choice. Then they ask for the removal of a healthy limb. At that point, the content of the request begins to reshape the judgment of the person making it. Autonomy shifts from a capacity belonging to the patient into a verdict on whether medicine accepts the intention. This is where the central clash of contested bodies becomes visible. The clash between medical and societal authority and individual and patient autonomy. The ethical toolkit has done its work. The Jehovah's Witness case showed us that medicine sometimes faces a choice between competing harms. BID creates the same kind of conflict. Beneficence gives the doctor a reason to consider amputation when suffering is severe and other treatments have failed. Nonmaleficence identifies the permanent physical harm of surgery and the psychological harm that may follow refusal. Justice asks why comparable forms of bodily modification receive such different clinical responses. Autonomy requires medicine to examine the patient's understanding, reasoning, stability, and freedom from coercion without treating the request itself as proof of incapacity. The 4 principles leave the case ethically open. Medicine's near-universal refusal therefore depends on judgments that lie beyond the principles themselves. Those judgments concern which harms medicine recognizes, which desires it accepts as authentic, and which choices it is prepared to treat as autonomous. Next time on Contested Bodies, we move from principles to practice. Episode 6 examines how doctors decide which requests for bodily modification count as legitimate and which are refused before the discussion has even begun. At what point does medical authority begin to redefine the patient's autonomy? I have argued elsewhere that a clear pattern appears in the way BD patients are assessed. Autonomy is treated as a property of the person until the person expresses an intention medicine finds unacceptable. That is where we go next. Episode 6, Who Gets to Decide? I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time. If you enjoyed this episode, please share it and follow Contested Bodies wherever you listen. Contested Bodies is independently written, produced and hosted by me, Leandro Loriga. The podcast receives no institutional funding or external financial support. This initiative was born from a desire to make invisible lives visible and examine the gray zones of medicine and the human condition. You can support the research, production, and future episodes through the donation link in the description. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time.